Now let's talk a little bit about workflow and roles. So in the emergency department, outpatient clinics, and urgent care. Several of you have, but have you worked in a medical environment? What environments have you worked in and in what role? What have been your experiences as a patient or the family member of a patient in different settings? And start thinking about where you ultimately might like to work. So the kind of personnel throughout these settings will sometimes be very similar. So usually there's physicians or a physician group, there's the front desk, registration personnel, nurses, generally a charge nurse, APPs are advanced practice providers, nurse practitioners and PAs, physician assistants, medical assistants, phlebotomists, radiology technicians, and of course, medical scribes. So how these personnel are used or organized may vary slightly from clinical setting to clinical setting. So our emergency department urgent care workflow is going to be very similar. So mostly for just the ED, there might be some pre-hospital care. So this might be ambulance, that kind of thing. Then there's triage, room placement, and an initial nursing evaluation. Initial physician, history and physical, initial interventions, the workup, procedures, consultations, reevaluation, and disposition. So many of these things, depending on the urgency of the reason why the patient's there, will happen all at once or in a slightly different order. We might need to do interventions, or the physician might need to do interventions prior to getting a full history. The ones in red are where the scribe would be involved. So let's break down each step a little further. So pre-hospital care before the patient arrives to the emergency department or the urgent care via private vehicle or EMS. I will tell you most often if a patient is going to urgent care, they're not coming via EMS. If a patient was transported via EMS, it is important for the care team to know what care was provided en route to the ED, and your physician will probably want to make sure that information is included in the HPI. Triage, so there's usually a designated area for this with triage personnel. This is where how quickly a patient needs to be seen is determined. Generally, if a patient arrives via EMS, they bypass this step. Room placement will also depend on the severity of complaint presentation. If you've ever been in the emergency room, you know sometimes this step can take a little longer. Again, if arriving via EMS, patient is usually roomed almost immediately. This is where they often change into a patient gown and get hooked up to monitors. Initial nursing evaluation. Each patient is assigned a primary nurse who will start gathering more information about the patient in general and further information about why the patient is there. Sometimes the ED provider is in there simultaneously, and IV access is often established at this point if necessary. Initial physician history and physical. So the doctor will perform the H&P with the scribe in the room. They will introduce themselves, and then you and your role. This is where your skills of observation and listening will become important. Each doctor will have their own flow and way of doing things, so you have to stay flexible and alert. Initial interventions. Some of the early interventions for emergent patients will actually occur before that initial H&P, but still note them for the HPI. The workup, this is the stage where laboratory and radiology studies may be ordered, and at this stage your job is to investigate past studies for comparison and to be on alert for results to notify the physician. And then procedures. Some patients may require procedures such as laceration repairs, bedside ultrasounds, endotracheal intubation, etc. As the scribe, you are to record all procedures performed by the physician in detail for billing purposes. Consultation. So they may consult other doctors to advise or participate in the patient's care. It is important for the scribe to note the name of the consultants and the discussions that take place. Exact details of conversations may be dictated directly to the scribe from the emergency room doc. Reevaluation. So depending on the condition of the patient, the doctor will return to the room several times to reevaluate and possibly perform more procedures. It is the medical scribe's job to record each of these things with times. And disposition, so the final destination of the patient. Admission, discharge, or transfer. Generally, the disposition is recorded by the scribe and the name of the accepting physician. This discussion between the doctors should also be documented. If being discharged, discharge instructions discussed with the patient by the doc should be noted. Some facilities will also have the scribe compile predetermined discharge instructions to print off and give to the staff to give to the patient. So again, it's not the job of the scribe to actually give the education, but sometimes it might be within their scope or job description to print off or compile the discharge instructions. What are some of the ways you think workflow may differ in a primary care setting? So you can see here there's fewer steps, right? We don't have that pre-hospital care. We don't have triage here. So we have the waiting room and registration, clinic room placement, physician evaluation, procedures, and disposition. So this is a simplified workflow, often in a clinic setting. In between registration and the clinic room, patients are put in a vitals room, or before they are seen by the physician, they see a clinic MA to have vital signs taken and basic information collected. So again, the red highlighted boxes are the ones where the medical scribe would be directly involved in documenting. So we've all had to check in before. That's our registration process when we're going to a primary care clinic. This can be manned by a nurse, an office medical assistant, administrative staff, then clinic room placement. This is where the initial vital signs or assessment may be performed by the OMA or clinic nurse. The physician evaluation, so that's your time to shine. This is where the scribe steps in with the doctor. Procedures, some procedures will be done in clinic, like wart removal, ejections, dressing changes. Those performed by anyone should be recorded in some capacity, but your job is to carefully document everything done by the physician thoroughly. And the disposition, future direction of care. Is there follow-up needed? Is there referral needed? You should document discharge education and instructions as they are discussed by the physician with the patient. So when I say this is where you come in, this is where you come in if you are a strictly clerical medical scribe. In some settings, you might also be the medical assistant, and you might be rooming the patient as well and taking their vital signs and putting in their vital signs and just waiting in the room for the physician to come back. So this will be highly dependent on your job description. But this lecture was made for strictly clerical medical scribes when it came to what is highlighted and what is telling you when the medical scribe will be there. So there are a number of links on here, and I actually already linked them under your week 7 Canvas course, so you can just press on them and they'll bring in the Canvas course and they'll bring you to the YouTubes. But it's just the first one is an inpatient scenario, so it'll kind of show you what an inpatient scribe is doing. And then a hospitalist scribe. So a hospitalist is somebody that's working in the hospital, so still inpatient, but not in the emergency room. And then the last one is an outpatient scribe, so working in a clinic setting. Again, these are linked in your Canvas course. These two links are about virtual and telescribes, which some of you might be interested in the future. Any questions, comments, or concerns, let me know. I want you to start thinking about how important you think the role the scribe plays in each setting, and maybe start thinking about what setting you might be interested in working in.